Thank you so much for having me. It's a pleasure to be here. Thank you for sharing this. So no potential conflicts to declare versus from the NIH and the American Thoracic Society Foundation. So I want to start with a question that I'm sure this audience has addressed, but just start briefly asking why we should care about dysynchrony in the first place. I think part of that comes from the Accurasis trial published by Dr. Patient's group about 9 years ago now. And they demonstrated a significant mortality benefit with cisatracurium compared to placebo. Now, while they didn't measure dysynchrony per se, I think there's an important secondary outcome of that trial that suggests that perhaps dysynchrony or patient-mental interactions were a mechanism of harm without paralysis or benefit with paralysis. And that's specifically that the incidence of both gross barotrauma and pneumothorax was halved among the patients who had received a paralytic. Additionally, aside from potential effects from preventing ventilation-induced lung injury, I think regardless of whether asynchronies cause lung injury, certainly they influence our clinical management with respect to sedation, for instance. And so if certain ventilator asynchronies do not cause lung injury, but we're responding to them by more deeply sedating patients, that certainly comes with cost as well. And so I think it's important to try to better understand underlying mechanisms driving asynchrony so we might know how to respond to them appropriately. So I think most people believe that perhaps one of the more clinically relevant forms of dysynchrony is this phenomenon called breath stacking with respect to ventilation-induced lung injury. So breath stacking is sort of loosely defined as consecutive ventilator inspiratory cycles with incomplete exhalation between them. This is what that looks like on a typical flow tracing of a patient. So you can see the first inspiratory cycle on the left, a brief exhalation in between, and then the second inspiratory cycle right afterwards. So, an idea that this is breath stacking, stacking literally implies that the two inspiratory volumes are on top of each other. So what you can see in this example here, this was a patient that was getting ventilated with a 400 cc tidal volume, which was about 8 cc's per kilo predicted body weight. So if that patient only exhales a little bit and then receives another inspiratory cycle, that cumulative effect is a 600 cc volume change, or about 12 cc's per kilo. So this was a patient who the ventilator settings said they were being managed according to the intervention arm of the original RZET trial. But if you actually looked at what the patient was receiving, it was much closer to the control arm, the high tidal volume arm of that trial. And while I think this has been recognized for some time, I think there's still a lot of misinterpretation of what's going on the ventilator here. And so even though it's so ingrained in our language, it's actually factually incorrect to say that the clinician is setting the tidal volume on the ventilator, even though that's exactly what that knob, if you will, is called in the ventilator. If you think about what you're actually setting, is you're actually only setting the inspiratory cycle volume. And so what that means is that in a sys control mode, for instance, the patient triggers a ventilator or the time triggers a ventilator. The patient gets an inspiratory cycle, but the ventilator does then not turn into a vacuum and suck back out that air. It's only pushing the air in, and it relies on either passive chest and lung wall recoil or active patient effort for that air to come back out. The reason that distinction, while somewhat technical, is actually quite important is because by definition, in assist control modes, the patient can determine the number and the timing of inspiratory cycles. And so therefore, the patient can actually determine the true volume delivered. If they decide to only exhale partially or not at all in between two inspiratory cycles, the result of tidal volume that patient will receive in actuality will be twice what you intended with what was said on the ventilator. So that's this phenomenon of breath stacking dysynchrony. So does this result in higher tidal volumes? Well, this was a cohort of 33 patients with ARDS where we compared the preset tidal volume to the cumulative volume change when this breath stacking phenomenon occurred. And you can see during the periods where patients were having breath stacking, the tidal volumes that they were getting were indeed right around 12 cc's per kilo. So this is the control arm of the RZET trial. And so it's very easy to imagine if a subset of patients is doing this quite regularly, that perhaps this would cause lung injury and potentially would be a mechanism of benefit of neuromuscular blockade in patients with severe ARDS. So how can you pick this up on the bedside? Well, aside from staring at the ventilator waveforms, which which maybe we all love to do. I think there's a couple of clues you can use to detect this, even not at the bedside, just by setting the ventilator in certain manners. And specifically, I think there's a real opportunity, especially for patients who are in volume preset modes, to use exhale tidal volume as a clue that this phenomenon is going on. Because my experience with most ventilators suggests that the ventilator is documenting the inspiratory cycle volume, and every time a new inspiratory cycle volume occurs, the ventilator resets that volume to 0. So it will never recognize the 400 plus 400 equals 800 on the inspiratory cycle side. All it's reporting on that VTI, the tidal volume inspiratory, is the individual cycle volume. So we'll only call it 400. But obviously that air has to come out somehow. And so if you look at the exhale tidal volume, you'll see much, much larger exhale tidal volumes than what the patient is suggesting, or than what the ventilator is suggesting on the inspiratory cycle side. And so I think there's an opportunity there, if you set your exhale tidal volume alarms relatively tightly, that this might be something you could pick up even if somebody has no experience with mechanical ventilation, just by having the event alarm of what's going on. So I think there are at least two different endotypes of breast stacking, which have been described by the gentleman to my left. So the first is this phenomenon of double triggering, and I think this is what most of us think of when we think of breast stacking dysynchrony. So if you look at the waveforms here, you see the top waveform, the esophageal pressure, dips down, there's a negative inflection in esophageal pressure, pleural pressure, triggering the first machine cycle. And then that patient effort, that negative deflection in esophageal pressure, stays negative throughout the first machine cycle and into a second cycle. So that one patient effort, a sustained inspiration, is actually triggering 2 breaths. So it's quite literally double triggering. One effort gives you 2 breaths. And you see this all the time at the bedside. This is a patient who is taking a big breath in. You might have a relatively short eye time because you have lower tidal volumes. And they're still breathing in when that first machine cycle is done. And if they're still breathing in, they can trigger a second inspiratory cycle with one inspiratory effort from the patient. And that will result in this breast stacking dysynchrony. And so we think this is largely a ventilatory drive phenomenon. So I think this is sort of the classic breast stacking, if you will. This is what we think of in a patient who is maybe not deeply sedated, or who has pain, or feels anxious, or a patient who has other factors that influence ventilatory drive, for instance, profound hypercapnia or acidemia, something that's really heightening their central ventilatory drive, causing these sustained inspiratory efforts. I want to contrast that with a separately described phenomenon called reverse triggering, which I think is a term that we're on to my different point. And so for a second here, I want to point out the waveforms, and then we'll ignore the waveforms. So with the waveforms here, you'll see the big difference is that the first inspiratory cycle is passive. There's no negative deflection in esophageal pressure. And then about near the end of that first inspiratory cycle, suddenly it looks like the diaphragm fires, there's a negative deflection in esophageal pressure, and that triggers a second breath. So it's a machine breath followed by a patient-triggered breath. So, and if you look at these waveforms over time, which I'll show you in a minute, this phenomenon happens over and over and over again in a very stereotyped pattern. So what could this be? Well, we think this is a neuromechanical reflex. And it might actually be part of the sort of preserved basic reflex in the fight or flight response, I think is how some people describe it. And so if you ignore the waveforms for a second, if you can imagine from sort of an evolutionary biology standpoint, let's think of a horse that's galloping or a cat that's running, for instance, because this has been described in both those kinds of animals. When an animal is trying to run away from a predator, that animal, it's most energetically efficient. The animal will have the greatest likelihood of escaping the predator if the animal is able to synchronize its breathing in a way that maximizes energetic efficiency. So that the way that the animal will do that is it's energetically inefficient to be trying to breathe in while your foot's hitting the ground. You can imagine every time you're doing that, your diaphragm is getting pushed up because your foot's slamming against the ground. And so what happens in these animal models is that when an animal is exercising or is running away as part of its fight or flight response, it's synchronizing its breathing to the rhythm of running in a kinesthetic fashion. So it's sensing the kinesthetic stimulus that's very repetitive, that's very stereotyped, right? When you run, it's a clear rhythm, it's not sporadic. And you start to synchronize your breathing to that phenomenon. So we think that's probably part of the fight or flight response in animals. This has been described in several human settings as well. So, and the OR has been described in patients who are, or first of all, it's been described in skilled athletes who are trained, who have trained their bodies to exercise very well. It's also been described in medical settings, including, for instance, in the operating room. So there it's been observed that if a patient is sedated but not yet paralyzed, while the machine is delivering passive installations, at some point the diaphragm or the respiratory system starts to recognize that repetitive, very stereotyped pattern, and the diaphragm starts to synchronize to it. So a patient who is completely comatose will start to have a respiratory pattern with patient effort that corresponds to the rhythm set on the ventilator. We think that's the same thing, whether it's the kinesthetic stimulus of your foot hitting the ground or the repetitive stretch of passive insulation from the ventilator. The body is seeing that rhythm and synchronizing to it. This has also been described in a sleep apnea setting in patients who have a backup rate on non-invasive ventilation, and by Bouchard's group in the setting of ARDS patients as well, again, who are deeply sedated, so suggesting that this is sort of a primitive basic reflex. Sort of highlighting how primitive and basic this might be, it was described in a case series in the Blue Journal of patients who are actually met legal criteria for brain death. So these patients met legal criteria for brain death. They put them on a set ventilator, or on a ventilator with a set rate, and then at some point the respiratory system saw that and started to synchronize to it. So it seems to be a very, very primitive reflex. The other point is kind of emphasizing the stereotyped nature of it. This is from Bouchard's report, where he looked at the timing of the entrainment effort. So if you have your machine cycle followed by the patient effort, how stereotyped or how regular are those two patterns? And he demonstrated nicely that the firing of machine followed by patient seems to happen at almost exactly the same intervals over time. So again, it's very different from how you and I normally breathe, which is a very erratic, non-stereotyped behavior. This is something that happens rhythmically over and over again. So what I wanted to end with today is try to make sense of this from my view as a clinician. So when I start to think of rhythms and rates and trainings and sort of central drive factors, this speaks to me a lot of how I would read an EKG. So I think if we look at the example of reverse triggering calipers that we would read in EKG, this will make a lot more sense. So this is a patient who has evidence of reverse triggering. So you see the red arrows at the very top of the screen signify machine breaths. So those are breaths that the inspiratory time, or that the respiratory rate on the machine was set to, that were being triggered by the machine itself. And you can see, for instance, on the, I think I have a pointer right here, do I? You can see, for instance, on the second and third breaths from the left, there's a clue that there's, just from the flow waveform, there's a clue that there's patient effort, right? The flow doesn't have a passive recoil. It kind of has that hump right after the machine inspiratory cycle is over. And if you look at the esophageal pressure tracing, there's indication that the patient is indeed making forceful inspiratory efforts at the end of that machine cycle. Now I said this had to be a stereotyped pattern, and it turns out actually that it is, even though this looks somewhat irregular at first glance. So if you take your EKG calibers and you put them on, you can see that the times where the patient effort does not trigger an inspiratory cycle are perfectly stereotyped. It's the exact same distance between each of them. But what's troubling is the fact that there is clearly some irregularity. But I think what's notable about that irregularity is that those are the breaths where the patient effort managed to achieve the second inspiratory cycle. And if you put calipers on those, you see again a stereotyped pattern there. And I think this really speaks to this being a neuromechanical reflex. So the analogy, again, I think clinically that we've all seen is, for instance, think about a premature ventricular contraction, right? When a patient has a PVC, there's a refractory period. There's this sustained pause before whatever the innate rhythm is comes back again. This is exactly what we're seeing here. You have PVC, if you will, an inspiratory effort that actually triggers the second inspiratory cycle. And when that happens, there's a pause before that underlying entrainment rhythm comes back again. So this is that same patient a couple minutes later. So here again is the entrainment pattern. You can see with intermittently actually resulting in breath stacking, or those two inspiratory cycles together. And then sort of exploiting this interpretation of the data, we performed an intervention that completely eliminated asynchrony. And that intervention was simply turning off the set respiratory rate on the ventilator. So this is a patient where we made no change to the tidal volume, no change to sedation, we did not give them paralysis. Simply by changing the set rate on the ventilator, you eliminate breath stacking dysynchrony, and you actually change the tidal volume that the patient's getting with that. And so if you put your EKG calipers on again, you can see here, once we turn off the rate, it's exactly the same stereotype pattern that we saw previously. And so this is an example of decreasing the rate, actually preventing reverse triggering and the associated higher tidal volume. And I think sort of colloquially, you would refer to this as an example of the ventilator actually overbreathing the patient, right? The patient had a rhythm, and we set the ventilator slightly higher than that rhythm, so that was resulting in the higher tidal volumes than intended. So just take away one of the two rhythm generators, take away the ventilator, and you see an underlying rhythm that causes no dysynchrony whatsoever. So what are potential treatment implications? Well, for double triggering, as we said, it's sort of a ventilatory drive phenomenon. For reverse triggering, this seems to be a primitive neuromechanical reflex, and I think the evidence for that is relatively compelling. So for double triggering, the treatment targets are things that would influence ventilatory drive. So you might manage your pH or PCO2 differently, trying to attenuate acidemia or severe hypercapnia. You might be more aggressive with treating pain or anxiety and choosing specific medications that would have that treatment effect. So additionally, you might, if you're managing the patient's sedation, you might preferentially use opiates to decrease respiratory drive. This sort of gives rise to the notion of lung protective sedation, if you will. On the other side, as a neuromechanical reflex, I think it's less likely that a reverse trigger will respond to these drugs. I think really what you need to do is you need to break that rhythm that is generating this syncing with the patient's internal oscillator. And so that might be coming up with novel ventilator modes, like maybe having a variable inspiratory time, or maybe somehow varying the rate or rhythm of the ventilator. So even if it's a set rate at 20, it's not one breath every 3 seconds, and perhaps that irregular rhythm on the ventilator would prevent this entrainment phenomenon from occurring. Additionally, this might be an argument for tidal volume variation. Again, just the idea that you're not having this very stereotyped rhythm that the patient will see and then entrain to. And lastly, well, this isn't necessarily proven, one of the interesting things I find is that this phenomenon of reverse triggering seems to be described primarily in patients who are deeply sedated, as in one study, or patients who are legally brain dead. It seems to be only, or patients who are sleeping, in the OSA literature, for instance. So it seems to be brought out by sedation level, and perhaps there's sort of a U-shaped relationship where you need some sedation to suppress ventilatory drive of double triggering risk phenomenon you're seeing at bedside. But that might be at the trade-off is increasing the risk of reverse triggering. So if you have a very deeply sedated patient, maybe that actually brings out this primitive kinesthetic neuromechanical reflex. And so perhaps these are patients where less sedation might prevent reverse triggering. And in both cases, the sort of end phenotype that you see at the bedside is unintended higher tidal volumes. And so I think in both cases, these could be a potential mechanism of benefit of neuromuscular blockade in severe ARDS. So with that, I want to conclude to say that breath stacking synchrony obviously results in higher tidal volumes than intended and often recognized. Perhaps we can use exhale tidal volume instead of setting that alarm a little more tightly as a clue that this is going on even if you're not sitting at the bedside. When that alarm is going off, then you can go to the bedside, look at the waveforms, and start to evaluate the two Dyssynchrony endotypes, double triggering and reverse triggering. And as we said, double trigger, if you want to have an analogy in cardiology for that one as well, maybe that's your atrial fibrillation. It's an irregular, erratic pattern, because that's how we normally breathe. In contrast, reverse triggering is a stereotyped rhythm. And so you would expect to see that constant rhythm, with the caveat that I showed that if occasionally that rhythm is actually resulting in a higher tidal volume, it's actually successfully triggering the ventilator a second time, you might see some erratic behavior, but again, it's still very stereotyped. You can literally take out your calipers, as we did, and see that that entrainment pattern is preserved. All right, thank you.